Good afternoon, everyone. Thank you for joining us for today's genetic webinar entitled Basics of Genetic Testing for Young Children with Congenital Heart Defects. This series is jointly provided by Texas Children's Hospital in collaboration with Baylor College of Medicine, Texas Health and Human Services, and the University of Texas at Austin, Texas, and the Texas Center for Disability Studies. Support for this presentation comes from the Department of State Health Services. Just a couple of accreditation and disclaimers here. The nursing accreditation and disclaimer slide has been displayed on the screen. If you are a social worker, licensed professional counselor, licensed marriage and family therapist, and licensed psychologist, and would like one free 1-hour CEU, this webinar has been approved for 1 hour by the University of Texas at Austin Office of Professional Development School of Social Work. The views and opinions expressed during this presentation do not necessarily reflect those of the Steve Hicks School of Social Work or the University of Texas. Nor does the mention of trade names, commercial practices, or organizations imply endorsement by the school or university. We will be sharing how to receive your CEUs for social work and nursing at the end of the presentation. We will be saving time for your questions at the end of today's presentation, but you can submit your questions at any time during the presentation using the Q&A box at the bottom of your screen. Today's presenters are Emily Soludczhk and Laura Buckner. Emily is a pediatric genetic counselor with the Cardiovascular Genetics Clinic at Texas Children's Hospital. She primarily works with patients who are suspected or known to have a genetically mediated aortopathy or congenital heart defect. She is the inpatient genetic counselor for the Texas Children's Neonatal Cardiac ICU. She helps to uncover possible genetic predispositions to cardiovascular disease and to communicate the information in a way that is easy to understand. She works closely with my families or families of TCH and Baylor College of Medicine to help identify informational, emotional, and psychosocial needs, while also guiding them through the medical and familial implications of genetic predispositions to cardiovascular disease. Laura holds a bachelor's and master's degrees in education, counseling, and rehabilitation. She is a licensed professional counselor and a certified mentor trainer in person-centered practice, the learning community for person-centered practices. Laura is experienced in educating others about family supports, state, local, and federal community resources for people with disabilities and their families, to program development and communication sharing success stories to impact change. As a family member herself, she specializes and especially appreciates opportunities to work with families and those who serve families. She says her most important degree is her MOM degree, a mom. Having parented her 35-year-old son, diagnosed at 3 months of age with a rare disease that includes IDD, autism, and chronic health issues. Laura says he has taught her everything she knows. Well, almost. Okay, at this time, I would invite Emily to share your slides.
Thank you, Gladys, and I'll go ahead and get started with sharing with these, and I would appreciate you guys confirming that everything looks okay on your end.
We can see it fine.
All right, perfect. Well, thank you again, Gladys, for your introduction. As she mentioned, my name is Emily. I'm a genetic counselor with cardiology at Texas Children's. I've been working with the kiddos in our unit for about 4 years, almost exactly at this point. And my section of the lecture today is the basics. And when we say basics, we really do mean basics. This could be a 4-day lecture if we wanted. But the basics of genetic testing when it comes to young children with congenital heart disease, or heart defects, actually, in particular. And so what are the objectives today? I'm hoping, again, with this crash course, that you'll be able to recognize some common genetic associations, so the very high yield conditions with our more common congenital heart defects. Also identify the clinical utility of identifying a genetic diagnosis in a cardiac patient who's quite young, so 0 to 3 years old. And so, how does having a genetic diagnosis actually impact their care or even benefit their family or their patient? Kind of branching off of that and somewhat into Laura's lecture slightly is also identifying the key psychosocial support for families, and why it's important for families to have a genetic diagnosis for their heart warrior and how we can go about broaching that topic. I think some people can be afraid to recommend genetic testing for their patients, unsure of how their families may react. And so I'm going to share some experiences I have with families and how they have shared that genetic testing was helpful for them. So first and foremost, many of you may or may not know that a congenital heart defect, so a structural anomaly within the heart, happens in 1 to 100 births. So it's very common, uncommon if you think about it in terms of percentages. But it's happening quite often. Many babies are born a day who have a congenital heart defect. Uh, I think in the world of genetics, we think, oh my gosh, it's a congenital anomaly. There has to be a reason for this. There has to be something else that's going on. But the truth is that most of the time we don't find an answer for why these kiddos were born with a congenital heart defect. Most of the time, that answer is multifactorial, which can sometimes stand for it's possibly genetic, but we're just not sure of what that genetic change is just yet. Or it can be due to a multitude of factors interacting together, such as multiple genes and environmental factors, or just fate. But there is also a significant amount of congenital heart defects that can be attributed to genetic associations. We typically quote it at about anywhere from 15 to 35-ish%. That number fluctuates, and you'll even see here on the slide 20 to 30%. That number fluctuates based on literature, and our knowledge is changing on a monthly basis at this point in time. And so we are rapidly discovering more genetic etiologies for congenital heart defects. But the most common cause of congenital heart defects you'll find are copy number variants or missing or extra regions of DNA, followed by single nucleotide variants, which are spelling changes or mutations, is maybe what you might have learned way back in high school when you probably last touched on genetics. And so, like I said, we're going to do a bit of a crash course in how to identify your kiddos that are most likely to have a genetic etiology. And so, being 1 in 100, we would love to be able to offer genetic testing to every single one of these kids. And you'll kind of hear me talk about later on as to why that would be important. But unfortunately, we just don't have the resources to go around and test everyone in Texas, and let alone the United States. And so what I'm hoping that you'll gain from this lecture today is helping to pinpoint characteristics or accompanying anomalies that can help you triage your patients and say, okay, this kiddo may benefit from genetic testing the most. And so I think we should prioritize their referral to genetics at this time. One of the most important factors for whether or not your patient or the family that you're working with could benefit from genetic testing in order to find a reason or a secondary diagnosis alongside their congenital heart defect is whether or not they have extra cardiac features. And these can vary, and we're going to talk about some of these more specifically with some case examples. But first and foremost are just extra anomalies. And so we can start with what may be really obvious to the eye, such as dysmorphic features. And so if we have malformed limbs, if individuals do not look like their family members, or if family members have maybe brought up the fact that their child looks different than their siblings. We can also see anomalies that maybe doctors have recognized and put in the chart. So examples could be macrocephaly, could be craniosynostosis, so kiddos that may need to end up wearing helmets. Other features that we can look for, and what's kind of nice about heart kiddos is that they get really good workups, especially if they've had congenital heart surgery within the first couple months of life. And so they are getting imaging done that a lot of kids may not have until a symptom or a problem presents itself. And so oftentimes infants or young children will have brain scans, such as an MRI or a head ultrasound. And here you can look for any brain anomalies. They will also oftentimes have renal ultrasounds. Red flags here, oops, sorry. Red flags here for genetics include single kidneys, horseshoe kidneys, a renal artery stenosis. Children who are growing way too fast or not as fast as you would expect. Growth can be a red flag for genetic conditions in children with heart defects, as well as skeletal anomalies such as missing or extra ribs or butterfly vertebrae. Oftentimes, these children also have chest x-rays in their charts. And another really big symptom is developmental delays. But what's more difficult in children who have had open heart surgery is because of the challenges that they've had to overcome in the beginning of their life when other kiddos may be rapidly learning skills, is that developmental delays are quite common. However, when you see developmental delays that are out of proportion to what would be expected for a kiddo who's catching up after their congenital heart surgery, that would be a red flag that maybe there's something else going on and maybe we should take a deeper look. This may also present as seizures that are out of proportion or uncontrolled, especially as well. And so if you've met a young child and all of their imaging looks good and maybe you don't have any suspicions, but you do know, or maybe they come from an outside hospital and all you know is that their mom or their dad told you what their congenital heart defect is, and you meet them and you have some concerns. Starting with one of our more common cyanotic congenital heart defects, so one of the critical CHDs, is tetralogy of Fallot, which is a combination of 4 separate heart defects, leading to a heart defect that needs to be repaired within the first 1 to ideally 6 months of life, depending on how significant some of the standalone defects are, so how bad your blood flow is obstructed. A lot of these kiddos, a significant proportion, up to within our internal data, around 40%, will have a genetic diagnosis. And so this is a very high yield congenital heart defect. And so if you see a kiddo with tetralogy of Fallot, you may want to say, I wonder if they've had genetic testing. Is this someone that we should maybe connect to see if we can work them up and help them out here? Like I said, if you have multi-system involvement, so if you maybe had findings on that additional imaging, your most likely diagnoses are 22q deletion syndrome. It's highest in the kiddos who had a fully obstructed pulmonary valve. And this is going to be your highest yield. And this is a condition that we'll touch on in the next slide, but it can somewhat slide underneath the radar due to its massive variability. The second most common diagnosis in these kids, which may be easy to recognize, but can sometimes be surprisingly missed in the newborn period, is Down syndrome. We can also see Alagille syndrome, which we'll touch on later. And other common syndromes that you may or may not be familiar with are Noonan syndrome, Charge syndrome, Goldenhar, and also some non-syndromic genetic changes. And what I mean by that are these are your mutations, your spelling changes, a lot of that impact genes whose only job is to tell the heart how to form. And so these genetic changes do not come with additional extra cardiac features. They do not come with additional medical complexities, but they do greatly impact that family's chance to have another child with congenital heart disease. And we'll talk about why that's important later on. And so I mentioned that the most common genetic diagnosis for kiddos with tetralogy Fallot, or sometimes called TET or TOF by cardiologists, is 22q deletion syndrome. You may be familiar with this being called DeGeorge. It's being slightly pushed out by the community members because it also has about 4 other names that were established a couple decades ago, and the community is hoping that people may lean towards calling it 22q11.2 deletion syndrome. But what's most important is how does this diagnosis impact this child's care? And so why do we care and why do we go looking for a genetic diagnosis? And how are we suspicious? 22q deletion syndrome is widely variable. We have many families. You'll see on the slide about 10% of the time a parent actually has passed on the condition, and they can fly under the radar. There's lots of symptoms. I always tell families there's a checklist of symptoms, but no one checks all the boxes, and some people might only check one or two. But our common features that we can see in people who are maybe more significantly affected are some common facial features. So children will still look like their families, but they may share features with other children of 22q. And so they have sometimes a stereotypical tubular nose, so a prominent nose. You'll oftentimes see prominent ears, so cupped ears that may stick out from the sides of their heads. They may have more deep set hooded eyes than their family members, and they can sometimes have strikingly long fingers, which I oftentimes tell families they may be really good at piano someday. Some other things that you may see in their medical chart, if you're a provider working alongside this family or this child, is they tend to have calcium abnormalities, so high calcium, which parents may relay as struggles with constipation or fussiness, or colicky baby is a common symptom that parents complain of or have concerns about. Velopharyngeal insufficiency is a common symptom, and they sometimes have immune dysfunction. It's not as common as some of the other symptoms, but you may notice that families say, my kid just gets way sicker than other kids at daycare, or I feel like he is coming home from daycare more often than my other children did. Could be a red flag for you to say, hey, maybe this kid needs some genetic testing. What's interesting and kind of will be a theme throughout this lecture is that the reason kiddos with 22q deletion syndrome, which is caused by over 20 genes located in the same region being missing on one set of chromosomes, is that the reason that they have congenital heart defects is because one copy of their TBX1 gene is missing. So the reason I say that is if a family says, hey, we're really worried about having another kid with a congenital heart defect, so we got tested for 22q and they don't have it. You may say, that's wonderful. I'm so glad that your child was negative for 22q, but if you really want to make sure that we've ruled out a genetic reason for their heart defect in the odds of that happening again, we may need to look a little bit further for genetic changes that won't impact your child's health beyond their heart defect. Another common condition that we briefly mentioned earlier is Alagille syndrome. Instead of being caused by missing DNA, Alagille syndrome is caused by genetic mutations, so spelling changes. Excuse me. These kiddos, again, may share some traits more similar to each other than their siblings. Oftentimes, they may have pointed, more narrow chins and more broad foreheads, leading to a more triangular shaped face. And they oftentimes will have jaundice, especially in the neonatal period and at young age. This is because in the chart, you may see that they have bile duct paucity or elevated liver enzymes or serum bile acids. They sometimes also have this eye finding called posterior embryotoxin, and butterfly vertebrae are a really big giveaway that a child may have Alagille syndrome. This would be an important diagnosis because we can kind of get ahead of the liver disease that comes along with this syndrome. And so while the family may be under the impression that the heart disease, such as Soludczhk flow, which is common, or also branch pulmonary artery stenosis was their biggest hurdle. And then if we identify this diagnosis early on, we can help prepare them for other symptoms that may come on later in life, such as liver disease, which can accompany Alagille syndrome. Next slide. Another heart defect that is not as common but has significant outcomes I wanted to touch on just because I think that we can really make a difference in these families' lives if we catch it early. And that is congenital supravalvular aortic stenosis. Congenital is a little bit misleading here because this is a rapidly progressive heart defect. It is not always noticeable on day of life one, but it can rapidly progress in a couple weeks and is most progressive within the first year of life. And so it's something we want to identify. And it is progressive if you have a genetic association. We do know that at least 50% of people with this heart difference will be positive for a genetic syndrome. And so it's important for us to identify that. Excuse me. First and foremost, 50% of people who have a genetic diagnosis that is the reason for their supravalvular aortic stenosis or SVAS, they have something called Williams syndrome. Williams syndrome is a multi-system disorder that causes a very stereotypical personality. Not every child with Williams syndrome will have the personality, but it is something that really stands out and is something that maybe the first feature that stands out to you as a provider working with these families or children. And that personality, the way I like to describe it, is very high emotional intelligence. And so these kids are not afraid of strangers. They'll run up to you, they'll give you hugs, they'll tell you they love you. And parents may say they're friends with everyone. And that may be a reason to think, I should see if this child maybe has this condition because I know that they also have this heart defect. Some other common signs or symptoms are if they have light colored eyes, their eyes will have these starburst patterns. They also have calcium issues. So again, constipation and diarrhea and colic are a concern of parents. This does cause intellectual disabilities and delays. Kids are usually a couple months behind their peers. They do meet their milestones, but they tend to be a couple months behind. And so that would be one of your flags there when you are thinking about whether or not this child should be recommended for genetic testing. Just like 22q, there is a specific gene within this deleted region, which is what causes Williams syndrome. And that, again, if it's mutated but not deleted, causes the exact same heart disease. So just because a family says we've ruled out that most common condition doesn't always mean that we've ruled out everything that could impact their child's care. Another common heart defect that has a very high yield is pulmonary stenosis. And whenever you see pulmonary stenosis, you should be thinking of a subset of conditions called rhasopathies. But most commonly, you should be thinking of something called Noonan syndrome, which some people may or may not be familiar with. It is a fairly common genetic syndrome. And just as we mentioned before, not only are there syndromic causes, but there's also genes that just simply cause pulmonary stenosis when they're broken. And so what might a child with Noonan syndrome look like or experience if you encounter them in your clinic space or working with these families? Oftentimes they can look pretty similar to each other, but just like 22q, they can also fly under the radar because the facial features or the physical features that sometimes we see in Noonan syndrome that can help point us in the direction of a diagnosis tend to become more noticeable and less noticeable throughout a person's life. It's kind of an ebb and a flow. And so what you may see is these individuals tend to have more deep set eyes that tend to slant slightly downwards. They may have a slightly larger head than other members of their family. They may have thickened earlobes. Short stature is quite a common concern for families, and so oftentimes the reason that they end up getting a genetic workup. And this is also oftentimes inherited. And so identifying it in your proband, your patient, your child can also lead to improved healthcare for other family members. And so why do we do this? Why does this matter outside of our curiosity of whether or not there's a genetic diagnosis that caused this child's congenital heart defect? As I briefly touched on, we know that whether or not you have a genetic etiology for your congenital heart defect can greatly impact what are the chances that you have a sibling or that family has another child who's also born with a heart defect. We'll talk about this in a bit of our psychosocial section, but these families are often fairly traumatized by their experience of having to witness their newborn or their very young child undergo cardiac surgery. And so a lot of them are really worried about what are the chances this happens again, especially if it's their first child. If we have no genetic testing, oftentimes we tell families it can be, depending on the heart defect, anywhere from about 3 to 10%, which is elevated from the 1% risk we all have. That can also change depending on your specific heart defect. And so we have more pinpointed recurrence risks for specific types of heart defects. But without any genetic testing, there's always an asterisk that because we don't know, it could be up to 50%. And without that knowledge, sometimes families can make family planning decisions that they wouldn't have made, or maybe they have perceived risks that are not actually the correct risks. It also can help us better identify associated anomalies. So how can we better care for these children moving forward? Pulmonary stenosis and Noonan syndrome. So if you help your family to get a diagnosis of Noonan syndrome in someone who has pulmonary stenosis, we know that up to 20% of them develop hypertrophic cardiomyopathy, which needs to be monitored. And someone with a successful pulmonary stenosis repair might otherwise be discharged. And cardiomyopathy can be deadly. We also know that ballooning in pulmonary stenosis does not work as well in people with rhasophases or Noonan syndrome. And so we may choose a better procedure in the first place so that we don't have to re-intervene. For individuals with 22q and tetralogy Fallot, they tend to have longer hospital stays. And so it can we can help prepare families for that. And we know that for those who do have the immunodeficiency, live vaccines can be slightly more dangerous for them. In branch pulmonary artery stenosis or tetralogy Fallot as well, when we see Alagille syndrome, so those kiddos who have the liver problems, they have an elevated, obviously, liver injury risk. And so that would be good to know about before major surgeries. And we also know that they have a higher mortality rate in their surgeries for tetralogy Fallot. And so that's something that the care team would most likely like to be aware of before they undergo any major surgeries. And also just kind of touching on that supravalvular aortic stenosis, with the red one here, because it kind of pops out, is that individuals with Williams syndrome or ELN mutations are at 100-fold increase for sudden cardiac death or essentially a heart attack when undergoing anesthesia. And so that is something that we would definitely want to know, especially if that heart defect is rapidly progressing in the first year of life. We want to establish that risk so that they are not undergoing anesthesia in unsafe environments. We also know that girls with Turner syndrome may have a more difficult time with a single ventricle repair. And so we may recommend something like transplant instead to these families. And as I mentioned before, those with 22q and tetralogy Fallot tend to have longer ICU stays and bypass times. And briefly touching on the psychosocial impact of providing families and individuals with congenital heart disease a genetic diagnosis, and kind of in the way I like to think of it, a plan. We know that having a genetic diagnosis, regardless of how it helps our families and our patients, it also helps the hospital and our healthcare dollars. Establishing a diagnosis has been proven time and time again to significantly reduce hospital dollars spent on inpatient care, and also just the length of stay and the number of hospitalizations that medically complex or children with genetic conditions experience. There was a paper, it was put out at this point around 10 years ago, and so there hasn't been any updates yet, but it was a study that surveyed parents whose child was born with a congenital heart defect and asked them about their stressors and just kind of their emotions surrounding that diagnosis. And they found that individuals whose child had a mild heart condition like an ASD, an atrial septal defect, all the way up to very complex heart defects such as hypoplastic left heart, which may result in a transplant. The parental levels of anxiety and stress did not vary between them. Parents hear that their child has a problem with their heart, and that's all they hear is that the heart is not working, and they are panicked. And so finding an answer for these kids does not it is not more important in the kids with more significant heart disease, and it is not less important than the kiddos with more mild heart disease. All parents are looking for an answer. And we'll talk about how not all of them are looking for an answer, but all of them have asked that question and have had that anxiety. And so these are all based on my personal experiences. As I mentioned before, I work in our neonatal ICU, and I offer genetic testing to all the babies born with the heart defect. And here's what I've heard from families when they talk about motivations for declining or accepting genetic testing. And I think some good talking points that can help you approach genetic testing with your families. And so how you can go about offering that so that they feel supported and accepted. So common family concerns that I hear, recurrence risk. I don't want to put another child through this. I don't think that we can do this again. And how genetic testing can help. You can say, I hear your concerns. I understand this is really stressful for you. Right now, that risk could be 50%. It's unlikely, but we can lower it to less than 1% with negative genetic testing. And that can be very reassuring for families. Or you could say, if we find a diagnosis, we can help you come up with a plan to have a safe pregnancy. Some families say, I want a game plan. I am a knowledge is power person. I want to know everything there is about my baby. I've already been surprised. I don't want to be surprised again. There are some nuances here. Genetic diagnosis can come with guidelines. It can come with management and things that we can do to help, but not all genetic conditions come with a guidebook. And so sometimes we're just as lost as we were before and maybe even more confused. But as I'm sure Laura will talk about, also having a genetic diagnosis gives you access to resources, and those are helpful. And those help families navigate the life of having a child with a CHD and a genetic condition. And some families say, why us? Why did this happen? And sometimes they're just looking for an answer. And if we can find a genetic result, that can answer their question, but also sometimes not having a genetic result is an answer within itself for these families. Reasons they say I don't want genetic testing. So reasons that they may be hesitant that you can talk with them through. The risk of uncertain results. Maybe they know that they'll be unable to cope with a result that does not come with a guideline or that we're unable to interpret at this time. Some families worry that finding a genetic answer, although most genetic testing does not immediately diagnose parents as well, but they feel that if we find something, they may assign feelings of guilt and blame to themselves or each other. And some other motivations reasons for families declining is also just not wanting to label a child. I always tell families that is not our goal. Our goal is to help enhance and personalize their medical experience and care. But some families just say, you know what, we've been through enough already. This is one test I can say no to, and we just want to treat our child as we can. And that's also an appropriate response from families. And I believe, and just as we talked before, just kind of really end on this point that just because they had one genetic test doesn't mean that we've ruled everything out and doesn't mean that they don't have a diagnosis. There are different forms of genetic variations, and there are different tests that are able to detect them. And so this is just a visualization here to hopefully kind of really bring home the point that it's not just a one-stop shop, unfortunately. And so we as genetic professionals are here to help you guys make sure that your patients have been appropriately tested and worked up and have the care that they need. And just don't be afraid to reach out and ask questions. I think we have resources, and then I can kick it off to Laura.
Thanks. And so you'll have to stop sharing your screen. Okay, you did. Hi, y'all. And Emily, thank you. That was so informative and helpful. I know for the people who are on the webinar today. So my name is Laura, and I always say my most important degree is my MOM degree, because I am a parent of he turned 36 on the 4th of July, 36-year-old young man with a rare genetic disease. Heart defects are characteristic in his disease, and we certainly monitored his heart for a number of years. And thankfully for us, that wasn't an issue, but we have lots of other issues. And so I just want to talk to you about, once a family's been given a diagnosis for their child, and they're reeling already, obviously Emily certainly spoke to the psychosocial concerns here, but the bottom line is you got to go home and live a life. And so I want to talk to you about how to live a life after you've left the hospital and the geneticist's office, and you take this kiddo home. The first thing I tell parents is inform yourself. Get as much knowledge as you can about what you're dealing with here. And certainly Emily has given you a good start on that. And I always say the most informative people, I mean, you've got Emily, she's a great expert. You've got geneticists, they're great experts. Your pediatricians, your medical professionals, all are going to be fabulous experts. But some of the best experts that you rarely think to look for are the people who are on the same journey as you are on. They also have a child with a cardiovascular issue, and they might even be a few years ahead of you. And so they have navigated the same systems and same concerns and same issues that you're looking at. And so find those people. And this is a little bit of how you go about that. I found some websites that I just want to recommend to people, and I put the links in on each slide, but this is kidswithheart.org, and it's specifically for people who are affected by congenital heart defects, regardless of what the congenital heart defect is. Emily gave you a lot of names, but bottom line, you've got a congenital heart defect. This is a good place to start. And I really like that they have a parent matching program. And this is mentioned here briefly on this page. You go to the website, you'll see more, but they will match. You could be a parent with a child who's been diagnosed with this rare genetic disorder or this cardiovascular issue, and you could contact Kids with Heart on their website, and they'll match you with somebody who's on the same journey dealing with a similar issue. And like I said, some of the best experts are the ones who are on that same road. Especially when you start dealing with systems, whether it's health insurance systems or Social Security system or Medicaid system, Health and Human Services systems, all of those systems are really important assets to our families and what they need. But they'll show up at workshops and they'll hand out their brochures and they'll try to answer your questions. But like I always say, they haven't stayed up till 3 o'clock in the morning trying to fill out their forms. And I have. So a parent who's a little bit ahead of you on this road has done the same. They've had to figure out how to navigate those systems. They've had to figure it out from a personal perspective rather than the professional perspective. It's invaluable help. Here's another important website you could look to: Pediatrics and Congenital Heart Disease. It's called upbeat.org. Again, a great resource for families. It could be a resource for professionals as well, don't get me wrong, but I encourage professionals to send families to these websites. Before the HIPAA regulations came on, and I'm old enough to remember before that time, doctors could say, here's a family I'm working with, and they have a child with the same diagnosis, and they welcome your call. They can't do that anymore. But these websites have stepped in that place. And so this is a place to send families for some of that support that they need when they leave the medical office. Marfan.org is a website specifically for Marfan disorder or Marfan syndrome, and they have a parent toolkit. It's a resource for parents who have been diagnosed with Marfan or possibly with vascular Ehlers-Danlos syndrome, some of those other syndromes that might be involved with vascular conditions. A whole parent toolkit, again, coming from people who've been on that road and know things that the medical professionals don't always have time or the ability to inform you about. This is another one this is a website specifically for Noonan syndrome. I don't have a website for every syndrome or diagnosis that Emily mentioned in her presentation today, but Google it And I guarantee you'll find some organization that is focusing on that specific diagnosis or syndrome. This is Noonan.org, teamnoonan.org. It's for Noonan syndrome. Again, a support systems in that bottom right corner. Even if you're just trying to inform yourself beyond what you learned in that immediate doctor's office or geneticist's office, because and Emily spoke to this, once parents hear there's a problem with the child's heart, that's all they hear. That doctor or that genetic counselor could talk a lot about other resources, but a lot of times our heads are reeling and we just don't hear everything that we really needed to hear. You could start with understanding Noonan syndrome, and it will often be explained in very parent-friendly language. This is another one called the vedsmovement.org. I've got an I itch, pardon me. Just another resource with resources and answers for when you're dealing with a situation you need more information about. This one is the Children's Cardiomyopathy Foundation. Again, another family resource website, because families have to go home and live a life. And sometimes that can be scary when you've got a kid with a significant medical issue. I always encourage families to keep really good records because they go to the doctor's office and the doctor will start asking questions. Have you seen this? Have you seen, when did that happen? How long ago was that? And your heads are reeling and you don't even have, was it last week or was it 6 months ago? You could, and this is just an example. If you Google cardiac observation checklists, there's a whole slew of them on the internet, but this is just an example of one. I have 2 pages here where you could check the symptoms or the behavior that you observe. When did you notice it? Was it in the morning? Was it in the afternoon? Was it in the evening? Sometimes I would even write down specific times. My son's disorder caused a lot of seizures when he was very young, and we kept very clear records about what we saw, when we saw it, where he was when it happened, and you could put that in the notes because all of that information can really help a medical professional drill down to what's actually happening, what they need to know, what they need to deal with. And so I encourage families to keep good records about what you see happening. Where did you see it happening? Who else was around when it happened? What time of day was it? What kind of food had they had to eat or not had to eat? My son's seizures, we always knew he was more likely to have a seizure if he didn't eat regularly. We always knew if his seizures stopped, it meant he had a really bad ear infection. But that came from really good record keeping and paying close attention to what we were seeing day to day to day. It also gives you a way to feel a sense of control in a situation in which you have so little control. There's a lot about your child's medical condition that you can't fix or control. And it means then there's a whole lot of other things that are happening in the family's life that are also not able to be controlled and not able to be fixed. Keeping a record like this, for me anyway, gave us a sense of, I wouldn't call it control, but we were managing things. We were paying attention, we were managing, and when we went to the doctor's office, we had good information to provide that then enabled them to provide us with good information in return and good recommendations. So I encourage families, keep good records. The last thing I'll talk about briefly, and I talk about this every time I speak to families or professionals, is about the Medicaid waiver lists. Every state has what we call Medicaid waivers. They're funded by Medicaid. There's a variety of waivers depending on what the child's need is or the diagnosis is, what supports are needed. And you don't have to necessarily know what supports your child might need right away or whether they'll even qualify or not. But the downside of the Medicaid waivers in Texas, and this is just really dismal news, but we have a 12 to 18-year wait list to get on a Medicaid waiver. And so I tell families all the time, and I speak to families with newborn babies I need you to call this number and put your child's name on this list. You don't have to know, you don't have to know why even right now, just put their name on the list, because you don't want to be 12 to 15 years down the road and realize he's going to need more support than I bargained for. And now you're behind the 8 ball, 12 to 18 years. The wait list, and the Texas calls it the interest list, because people are interested in services, but those in the disability advocacy community call it a wait list because you're waiting. And there are over 100,000 people in the state of Texas currently on those lists. So if you want to get more information about the Medicaid waivers, because no offense to Health and Human Services, they do fabulous work, but a lot of this information on the waivers on their website is a little over people's heads if you know nothing about Medicaid and Medicaid waivers. So I encourage families, go to this link that I have on the slide. It's at a website called Navigate Life Texas, which is an amazing website, specifically as kids get closer to transitioning into adult health care. But they have a whole page on the Texas waiver system. They even have a video of a parent speaking about the waivers and what they mean and how you do it. It's all explained in very parent-friendly language. So I encourage you to start there. But what I will tell you about when you add a name, and sometimes I'll tell professionals, don't just tell parents about this. Give it to them in writing. Perhaps even get the social worker or somebody else on your staff to make the call with them. Because again, their heads are reeling and information is flying by and they're not going to retain all of it. And we don't want this to get lost. When you're adding a child's name to the Health and Human Services waiver list, you do not have to qualify to get on the list. Sometimes you'll get somebody who thinks you have to qualify when they're answering the phone. They're just new staff. They don't know better. You do not have to qualify to get on the list, nor do you need to know what your child will or will not need, or even if they will qualify when their name comes up. You don't need to know any of that. You just put their name on the list, because when their name comes up, that's when you determine, do they qualify? And if so, what services or supports are needed? The information that you will be requested to provide on that call is the child's name, their date of birth, social security number, some demographic information, and there's a very brief questionnaire that the HHSC people have come up with. You will be given an ID number, and I tell families, don't lose that. Put it in a lockbox. Don't lose the ID number, because that's how you keep track of where you are on that interest list. And they now have a website called yourtexasbenefits.com. You can go on and apply for benefits there. But more importantly, once you've put your name on that child's name on that list, you can keep up with that ID number on that website and just see where you are on the list. Sometimes it's discouraging, but it lets you know what's going on. These are some helpful phone numbers about getting your child on the interest list. It depends again on the child's diagnosis. Emily spoke about some of these children with cardiovascular issues are going to have developmental delay. That's going to qualify for them for some different Medicaid waivers than a child who doesn't have any developmental delay. At the very least, with a cardiovascular health issue, I would imagine you would qualify for the children with, now I just lost the name, CDMP, children's CDMP. I'll think of it when I'm not trying to think of it. And so I tell professionals, if professionals are on the call, do help with the Medicaid waiver list. Do give the families this information in writing, or suggest a loved one help make the call so it doesn't get lost in the midst of everything else. Or more importantly, even make the call with them. It only takes 5 or 10 minutes at best. And then do remind them to update their information annually. You can go to that yourtexasbenefits.com website, because if let's say you move or your phone number changes, your address changes, and you don't notify Health and Human Services about that change in contact information, if your child's name were to come up on the waiting list, and they can't find you, they will fall off the list. We don't want that. And so these are some benefits that families might qualify for. And the last thing I'll speak about, and Emily certainly began to address this as well, is that when you go home with a child with a medical condition you weren't expecting or a medical diagnosis you weren't expecting, and it's going to change your life. It's going to change their life, sometimes in really, really big ways and sometimes in not so big ways. But whether it's big or little, it rattles you. It's alarming. And many times, and Emily spoke to this, many times families will need some professional help. You might see some symptoms of anxiety or depression. I encourage you to look for a support group. If you can't find, my son's disease is rare. We don't have a support group anywhere near me, but I'm associated with the National Alliance, and I'm connected with people all over the country who share my son's diagnosis. And so even if you can't find something locally, you can certainly find support online. With Facebook becoming what it is, you could put your child's diagnosis into Facebook and find a slew of Facebook groups, parent groups, professional groups who are talking about that specific diagnosis and providing support to each other. I'm certainly a part of those groups as well. Last thing, and I just really want to emphasize this, is you can't make your life or your child's life all about that diagnosis, because all of us have something going on medically or will, and none of us want our lives to be focused solely on a medical diagnosis. So we have to live a life outside of the medical diagnosis and with the medical diagnosis. Look for passions and hobbies that align with the family and the child's energy levels. It might mean you go for shorter periods of time. It might mean you take breaks in between, those kind of things, but you look for those things anyway. You take travel, you pursue education, you explore relationships with people who are in similar journeys as yours. And lastly, just believe in what's possible, because as much as the doctors and geneticists know about your child's diagnosis, they do not have a crystal ball. Nobody does. And their job is to tell you everything you might need to know about this specific diagnosis, including how bad it could get. They can't paint a rose-colored glasses picture with a serious diagnosis. That wouldn't be fair to you. But your job, the family's job, is to have hope and believe in what's possible. With the advent of technology in our recent years, things are changing dramatically for our kids with serious medical issues and support needs. And we have to believe in their potential and help them be everything that they can be. And there's my contact information. I'm shutting it down just a little bit early in case there are any questions. If I didn't answer something, or you're looking for a website I shared or more information that we didn't have time for today, please feel free to email me, and I'll see if I can answer you, or if I can't, I'll find somebody who can. And I will turn it back to our coordinator, Gladys. And I thank you all for being with us and for your time today and for what you do. Thanks.
Thank you, Laura and Emily, for your presentations. At this time, I would like to invite anyone to enter any questions into the Q&A box. I see that we already have a couple of
Oh, and thank you. Nina added the name I could not come up with off the top of my head. It's MDCP, Medically Dependent Children Program. And so you may very well qualify for that with some of the diagnoses we've discussed today. Thanks.
I think that adds on to like the importance of early diagnosis too. Laura, thank you for touching on that, because the amount of times I have to tell families it's a 12-year wait, and seeing the look in their eyes it's scary.
It's a 12 to 18-year wait.
Yeah.
I put my son on a wait list when he was 15, and he came off at 33. It's dismal. I'm sorry to say. Texas is at the bottom of the barrel in terms of how we support children and adults with developmental and intellectual disabilities, medical diagnoses. Dang it.
Yeah.
someone said, thank you for the link to use as I see families. And someone else would like a copy of Laura's PowerPoint presentation. Yes, Laura and Emily, if you can send me your PowerPoint presentations, we can certainly include those in the email that will go out to everybody.
Sure, thank you.
Okay, any other questions in the Q&A? I don't see any more. Laura, Emily, anything else that you would like to share?
No, I don't think so. I saw something coming Q&A just now.
Okay, I missed the first 20 minutes, but here is a great resource for children and families with genetic heart rhythm disease. It's called SABS Foundation.
Well, thank you. Good to know.
I think on the topic of support resources, and again, just echoing Laura, thank you. Like the Marfan Foundation is fantastic. So is the VEDS movement. And as Laura mentioned, you can definitely find help out there and people out there, especially if you find like a rare diagnosis. But also a word of caution that not all advocacy organizations are the same. Some are very helpful. Some are maybe more parent run who don't have the resources to help them. And I always do warn families, especially after a new diagnosis, that people go online because they need help, or people go online in order to be a source of hope, and that most people are going to fall somewhere in the middle. So when you're prepping families to go online, just kind of prep them like, hey, not everyone's story, just like Laura said, is going to be yours.
Right. Dr. Google is not your answer.
No.
Looking for an organization that specifically focuses on your child's diagnosis as a starting place.
Great. Okay, well, there's no more questions in the Q&A box. So thank you very much. And once again, we're grateful for your time and everybody's participation in today's webinar. If you're viewing the live today, within 24 hours, you will receive an email with survey links for both social work and nursing evaluations. And this needs to be completed to receive your credit. The email should be in your inbox tomorrow. We did have a couple of hiccups the last webinar, but we've streamlined this process, so you should get it within 24 hours. Once the survey is completed, you will receive your certificate of completion within 48 to 72 business hours. However, if you are viewing the recorded version of this webinar, this session is not eligible to receive CEUs from the recording. If you have any questions about this session, then please feel free to contact me, Gladys Pryor, at gladys.pryor@bcm.edu. Our next webinar in this series is titled Understanding Developmental Delays and Disabilities. And will be presented by Dr. Holly Harris with Baylor College of Medicine and Texas Children's Hospital, and Laura Buckner, who was on our presentation today. The session is scheduled for Wednesday, July 16th at noon. A registration link for this upcoming webinar will also be included in the email containing the information about your survey. And we hope you can join us in the future. Once again, thank you very much for your time, and this concludes today's webinar. Have a great afternoon.